Good afternoon.
Yes, good afternoon, sir.
Yeah.
Good afternoon.
Yeah. I hope I'm audible, madam.
Yes, you are audible.
Yeah.
You are audible?
Yes. Little disturbance is there, but it's okay, ma'am. Fine.
Okay. Sir, with your permission, Dibendu will
Good
start.
afternoon.
Yeah. Mr. Anjan Niyogi can start his presentation. We wish him the best of luck. Yeah, he can please start the presentation.
Start.
My topic is analysis of the factors influencing purchase intention of hearing aid users in Dibendu, India. So, my supervisor, Dr. Pradip Kumari, she has helped me a lot during this entire journey. This is basically the action taken report. The questions that was raised by both the examiners. I tried to compile all of them, and this side, the changes that I have provided in the thesis, I have mentioned the page number as well. For example, one of the examiners had asked to use the word users in the entire topic, so I have used that. Then, as you see, the research methodology, there was a requirement regarding the explanation as to why the age group of working population is considered, that I have mentioned in page number 1 to 112. Similarly, if I come down, so far as the original contribution by the scholar, this has contributed in chapter 5, page number 212 and page number 213. All these details has been incorporated in the thesis. Now I start the proper presentation. Minimize that. Yes. This is the agenda of today's presentation. First, I will discuss as to why I have selected this topic, the basic concepts, literature review, summary, and research gaps. Then the research questions, research objectives and hypotheses, research methodology, the respondent's profile, data collection procedures and tools, data analysis and discussions, implications and limitation and future scope. Now, first we start with why this topic. If you see, basically, if we consider hearing loss, these are the major factors for which people come across hearing loss. Hearing loss is not actually for a particular age group. It can be hearing loss can happen to a newborn baby. It can happen to a aged person, or it can happen to a middle-aged person also. To start with age, if I say hearing loss, at times elderly people face hearing loss, that we say presbycusis. So that's related to age-related problem. Then we have got the medical conditions. When medical conditions, when we consider here, we are talking of when people has got any other ailments such as heart problem or high blood pressure. They can have hearing problem because they are interconnected problems. Then ototoxic medications, if I say high dosage of steroids can lead to hearing problem. Genetic factors, if we say if parents have got hearing problem, for example, mother or father has got hearing problem, then this problem of hearing loss can affect. And noise exposure, when we say noise exposure relates to the when people are exposed to excessive sounds, then hearing problem can develop. Obviously, it's not that only if person is exposed to loud sound, hearing problem will be there, but continuously if people are exposed to loud sounds, nowadays people are more using audio systems. When people are working in a factory where high decibel sounds are there, chances of hearing loss is always there. Now we try to project as to what is the current situation of hearing loss globally. If we see today, around over 1.5 billion of the population globally is affected with hearing problem, and in our country, if we consider, in our country, it's around 7% people have got some form of hearing problem, although only 0.5% actually really goes for a hearing solution. Obviously, I would like to say here, hearing solution doesn't mean taking a hearing aid. Hearing solution means some form of medication or consultation to a doctor, with a doctor or audiologist, whereby if there is a requirement, hearing aid comes in, which I will discuss little later. Now, addressing the global burden of hearing loss. Now, when we say the how to, what are the effects of hearing loss? On the right hand side, I mentioned the effects of hearing loss, and on the left hand side is the process to solve the problem. To start with, when a people has got a hearing loss for a long period of time, actually the person's overall communication as well as his lifestyle, quality of life completely changes. First of all, the communication difficulties comes in. That person becomes very introvert. He or she do not tries to communicate with people because he finds very difficult to communicate with. This just come down. Should I see this? Okay, this will not be the camera. Only use. Okay. So this communication difficulties does comes in along with misunderstanding and frustration. Obviously, what happens when a person is having a hearing problem, it's not that that person do not gets completely disconnected with what is being said, but at times what happens, he only gets 80% of the hearing, 80% of the words that's being spoken, or 70% of the words that's being spoken. So in that case, what happens, that person actually misunderstands what's being spoken, and he takes lots of time to understand things, whereby he gets frustrated as well. Reduces the overall quality of life, because the hearing challenge actually affects him so much that the normal joy in his life actually goes completely way off, and he becomes completely isolated and lonely. So in order to solve this problem, we can address this in three basic ways. One, early identification and intervention, whereby whenever the problem is there, it is identified and proper take care is taken. There are quite a few tests that can be conducted to identify a person is suffering from any type of hearing problem. Then we have got prevention. When that hearing problem is identified, proper prevention measures can be taken. It's not that the person is having a hearing problem, then only prevention will be taken. It can happen with a normal person hearing also. For example, we shouldn't use stereophonic sounds on a longer period. Exposure to loud, stopping exposure to loud sounds is one of are the few preventive measures we can take care, so that we can prevent the hearing loss to happen. And thirdly is the rehabilitation procedure, whereby once a person is having a hearing loss and that hearing loss is related to nerve deafness, then obviously hearing aids, cochlear implants, auditory training, quite a few things are there which can be undertaken in order to provide a normal life to that person and to bring back the joy in his life and to provide a proper quality living. Now, towards the solution to hearing problem, these are the four ways we can solve this problem. These are, as I said, hearing aids, auditory training, assistive listening devices, and cochlear implants. It's not that it depends on the patient to patient, as well as the patient's economic condition, the patient's present history as to what are the challenges the patient is facing, and based on that, one of the solutions can be taken up to take care of the hearing problem. Next, we come across as so far as hearing aid is concerned, how far hearing aid is helpful. We mentioned five important heads. These are: it provides increased quality of life, enhanced social participation, improved communication, economic benefits, and cognitive benefits. So far as increased quality of life, actually once a patient starts using a hearing aid, he or she is able to communicate with others. Thereby what happens, he becomes more friendly, as well as that person is able to understand what's being spoken. So that actually creates overall happiness and increases the quality of living. Enhance social participation. The person who has got completely isolated and introvert, now that person takes the extra effort to get socialized. He or she participates in social gatherings, in parties, as well as in office discussions, and thereby he becomes more and more active person. Improves the communication, not only in the one-to-one communication, but in group discussions, in telephonic communications. All forms of communications becomes quite easier. Economic benefits, because once a person is having a hearing problem, actually till date society do not provide that much support to that person, and that person might struggle in his job. He might not get a good job. Once he or she is getting a proper hearing aid and that person is able to communicate, he or she gets a better job, or can do whatever work he is doing and get paid according to his talent. And further, the cognitive benefits which are there, the neural problems, further deteriorations are taken care of. Now, addressing the common concerns of hearing aid, in India we have around 63 million people suffering from hearing loss, and where the major challenges so far as hearing aids is concerned, it's about the cost, it's the stigma, the social thinking of the people, as well as the cosmetic look of the hearing aid. And how we can mitigate this problem? We can expand the access to hearing healthcare services. We can request the government to think regarding the subsidies and insurance coverage. We can think of public awareness campaigns so that people are aware of as to how to protect their ears, and if there is a problem, what are the solutions to it, and training and educating people so that how this problem can be mitigated. Now, this is so far as the hearing aid market in India is concerned. If we see the journey from 2019 till date, till 2025, there has been obviously a good growth rate, and by 2030, if we see, the figures will actually double to what we had in 2023. So there is a gradual rise in the overall hearing aid market, which indicates that people are accepting the hearing aid as one of the solution to the problem. Now, this is the overview of the research that has been undertaken. First, we started with the objective of this study, where we defined the objectives. Then we had the research questions. Based on the research questions and objectives, we did a rigorous literature review. Based on the literature review, we had developed the hypothesis. Based on the hypothesis, we had conducted a proper research plan and collected the sample. After collecting the sample for the pilot study, we did changes in the questionnaire. We did quite a few modifications. We did the reliability test to see how robust our questionnaires are. And based on that, we have collected the final data, which we had analyzed, done the hypothesis testing, then we had done the interpretation, and finally the thesis has been prepared. Now we come across the theories, the literature review, and the gap analysis. In this study, I had considered two major theories. One is the theory of plant behavior, and the other theory of health behavior model. Basically, if we see, these two models are basically relates to the buying behavior of the individual. So far as the health belief model is concerned, here basically we are looking into the perceived severity of the problem, the threats which we come across, the benefits, the suspectability of the problem, looking into the clues to action, the solution to the problem, and ultimately coming down to the self-efficacy. Similar to that, we have also looked into the theory of planned behavior, where we have looked into the attitude towards the buying process, the subjective norms, and the ultimately we have looked into the actual behavioral control. In both the cases, what we had seen, earlier studies which were conducted, mostly in those studies, it was seen that hearing aid, any analysis, it was seen that hearing aid satisfaction level was conducted. Moreover, how people are accepting hearing aid as a solution to the problem. Buying behavior, so far as my research goes, I haven't found any proper study where they have meticulously considered buying behavior as the process to go on. And this two theories actually associates with the buying behavior. That's the reason why we had selected both these two theories. This is the entire research literature review that has been conducted. As you see, total 279 was the figure that was seen, out of which the last 5 years it was around 105. It consisted of thesis, journals, books, as well as magazines relating to this topic. Based on that, the research gap was defined and the conceptual framework. In this diagram, if you see, this is the area of literature review. During the literature review, we had seen that basically these are the 7 constructs which we had identified on which the theory, on which this thesis stands. Those are the perceived benefit, physical comfort, psychosocial factors, service expectation, orthodox beliefs and customs, disease and health issues, and price sensitivity. Maybe one thing I would like to mention here is that in all the research literature reviews that we had conducted, either they had considered perceived benefit or they have considered cost as a factor or price sensitivity. In none of the earlier researches, all these 7 factors were considered. In our thesis, in the later stage where I will mention that these 7 factors have been playing a very pivotal role in the decision-making process. Further, this during the literature review stage, we identified that it's not only the user who is playing an important role, but there is a role of the stakeholders who are the here. The ENT specialists, the doctors, the audiologists, the healthcare workers, the family members, they also take a very pivotal role so far as the decision making is concerned. So we have tried to incorporate in this research the viewpoints of the stakeholders as well, because they are one of the key factors so far as decision making or buying regarding the hearing aid. This is few of the research that I have mentioned here. As this is relates to a particular age group of 16 to 55 years. It needs to be mentioned here why we have selected this age group of 16 to 55. Mostly, it's not that hearing loss, as I said, is not restricted to a particular age group, but we have to understand this 16 to 55 years age group are generally the working population, who are mainly the breadwinners of the family, and the hearing loss which they face are mostly noise induced hearing problem or hearing problem during their work process, or maybe they have got a congenital hearing problem since birth, which they are continuing. So these people are facing this hearing problem, and along with that, they have to do their daily work where they are exposed to dynamic noise environment. When they are at home, the noise environment is completely calm and quiet. They are actually speaking with one-to-one situation while they are in the roads or in their offices or in colleges. If I consider a student of 16, 17, 20, 21, they are in the classroom, they are facing lots of sounds whereby they need to communicate. So that's the reason why this age group was selected. Moreover, I would like to say in the research gap, I will mention that in the research gap, that based on the literature review that has been conducted, these were the major research gaps that was observed. One, the lack of research on hearing aid purchase process, both from the user and advisor perspective. Combined user advisor studies are rare. It has been seen that in studies, either the user perspective is mentioned, whereby people mention their acceptance of hearing aid or non-acceptance of hearing aids, or the role of audiologist, a role of doctors in prescribing hearing aids, but considering both side viewpoint and ultimately coming down to the purchasing process has been a rare during the literature review we had conducted. We found it was quite rare to identify that. Next, there has been a very limited research so far as the legal, ethical, legal findings so far as hearing aid dispensing in our country is concerned. If we compare this with the European countries or in the United States, obviously there are many ethical standards that are always there, whereby those protocols needs to be followed while providing hearing aid. Till date, in our country, we do not have a proper protocol so far as from the National Institute of Hearing Handicap. Also, quite a few directives are mentioned which needs to be followed, but certain rules and regulations hasn't come in place. So there is a gap in that. Next, studies often focus solely on one of the factors, such as the physical or health benefits, the psychosocial factors, the user expectation, the post-sale service, the constructs which I have mentioned that, but considering all those constructs under one study hasn't been identified. This research mainly the researches which has been conducted mainly focuses either on the elderly citizens, that is age group above 65 or 60, or the pediatric where the newborn or 2 years, 3 years old populations, the researches have been conducted. It's not that research on the middle age group or the working population hasn't been conducted, but the number is comparatively low than these two groups. There is a required research is required so far as evolving in the commercial environment and the socio-cultural factors, which actually, if we consider in our country's perspective, plays a very pivotal role. Those areas has been a gap so far as the research gaps we had identified. Based on the entire research gaps we had identified, it was not possible to consider all those in this research. Maybe on a later stage, others gaps can be considered. We have again minimized our gaps, which we minimize the gaps which we can undertake in this research. And in this research, basically what we have considered that major gaps so far as from the hearing aid stakeholders' point of view, there hasn't been a holistic work so far as the users as well as the advisors' point of view, as I mentioned in my previous slide, which I have considered in this research. Then the shifting of the focus so far as the constructs are concerned, the psychological factors, the perceived benefit, the health and disease issues, the post-care benefits, all those affecting the overall purchasing has been considered. We have considered a broader scope where we have not only considered the urban population or rural population, but we have considered a blend of both these areas to identify the trend in the buying pattern. The age group that we have considered is 16 to 55 years, and this research actually goes beyond the focus and incorporates previously neglected aspects such as it investigates under-researched regions, populations, and delves into the factors driving hearing aid acceptance in specific and in specific groups. Next, we come across the conceptual framework. Based on the literature review that we had conducted, these are the 7 constructs we have considered, which are physical comfort, psychosocial factor, price sensitivity, perceived benefit, orthodox beliefs and customs, diseases and health issues, and service expectations. Then we come across the objectives and the hypothesis. The objectives of this research was to identify the factors that influence customers' purchase intention towards hearing aids. Number 2, to examine the most influencing constructs of customers' purchase intention towards hearing aids. Next, to analyze the demographic variables of customer purchase intentions towards hearing aids. Based on the objectives, we have developed the research questions, which were how positively do usefulness, ease of use, marketing initiatives, social influences, consumer influences, technology, cost affects the selection process of hearing aid. Number 2, how to understand the influence of the psychosocial factors on intention to buy hearing aid. Number 3, the obstacles faced by persons while selecting a hearing aid and what are the parameters which affects the selection process. And number 4, we have considered the demographic factors where we have considered factors like gender, occupation, academic qualification, age group influences the buying intentions of hearing aid. Based on that, we have developed 12 hypotheses. The first hypothesis was physical comfort does not influence the purchase intention towards hearing aids. Second hypothesis, psychosocial factor does not influence the purchase intention towards hearing aids. Third hypothesis, price sensitivity does not influence the purchase intention towards hearing aids. Number 4, perceived benefit does not influence the purchase intention towards hearing aids. Number 5, orthodox beliefs and customs does not influence the purchase intention towards hearing aids. Continuing the hypothesis, the sixth hypothesis we had, diseases and health issues does not influence the purchase intention towards hearing aids. Number 7, service expectation does not influence the purchase intention towards hearing aids. Number 8, gender does not influence the purchase intention towards hearing aids. Number 9, age group does not influence the purchase intention towards hearing aids. Number 10, there is no significant relationship between qualification and purchase intention towards hearing aids. Number 11, there is no significant relationship between occupation and purchase intention towards hearing aids. And number 12, there is no significant relationship between monthly income and purchase intention towards hearing aids. Then we move to the research methodology. In the research methodology, we had conducted convenience sampling. First, we did a pilot study. As I said, the target group was from 16 to 59 years population. We had collected data on a two-way basis. One, we had created a questionnaire where we had a questionnaire where the questionnaire was of two parts. First, we had the general questions regarding the user's personal details, and then we had the specific questions which we had considered in a form of a Likert scale, 5-point Likert scale, where we have started from 1 to 5, and we had asked the respondent to give the numbers so far as their acceptance level is concerned. Along with that, we had done a focus group discussion as well to identify the understanding of the persons using the hearing aids and their emotional feeling so far as using the hearing aid is concerned. During the pilot study, we had conducted the study for total 70 impaired persons, out of which within the target population which we are going for, we had 60 respondents. This was conducted in September 2023, and the total number of questions was at that time 47. But later, based on the reliability test, we identified that few of the questionnaires were not at par. So we had to reduce the number of questions, and from 47, we ultimately went with the actual study, we went with 43 questions. So far as the Likert scale in the pilot study, it was 7, which was again reduced to 5. But obviously, the quality of the research was maintained, and in order to keep up the requirements, we had to do that. Now, so far as the total sample collection is concerned, total sample collected was 439, but few of these samples were not many, especially the female respondents, due to their hesitancy of not revealing their hearing problem. Although they were in the camp in which we were conducting the study, but they did not respond because they didn't wanted to declare their hearing problems to the entire society. So that's the reason why, although we had total 439 samples, but ultimately we came to 389. Another thing I would like to say here, that we have done a convenience sampling where we have collected data from different audiology clinics, from hospitals, from doctors' chambers, from audiologist personal chamber, and since convenience sampling has got a few limitations, we have done multi-level convenience sampling in order to reduce the bias which is there so far as convenience sampling data is there. Along with the quantitative study we have done, we have also gone with the qualitative study where we have gone for a focus group discussion. In the focus group discussion, total 34 participants were involved, and we selected participants who had a minimum experience of 6 months and a maximum experience of 12 years, so that after using their hearing aid, what are the challenges they are facing, they can easily say, because a new user might not reveal the problem, or they might not be aware of all those things. Of the total 34 participants, we divided the interviews into small groups, Each group consisted of around 5 to 8 5 to 8, and each group discussion averaged around 25 to 30 minutes. The basic intention of this focus group in the interview was to identify or understand the challenges which a hearing aid user faces while buying the hearing aid, and even after buying the hearing aid, what are the factors which affects them so far as buying the second hearing aid is concerned. Because in our study we have considered one of the factors as post-sale service or service expectation, where where only after purchasing the hearing aid people understand what is the service quality they are facing. And since it's a health product, the continuous service is a very important factor so far as the continuous service is very important to provide a satisfactory user level. So that's the reason why during the focus group discussion we have kept question starting from regarding their hearing problem, since when they had their hearing problem, what are the challenges they face, how supportive are their family members. This is a basically in these two slides I have tried to provide a summation as to the questions which we had asked. Compared to the normal questionnaire which we have used for data collection, in the focus group discussion, although questions were written, but based on different groups' needs and requirements, and the language of the question was changed in order to understand the pulse of the participants. Now move across the demographic profile. Of the total participants we had, 73% was male population and 27% of the female population. Here also I would like to mention that this data that we had collected, since many female respondents did not provide the permission to give answers to the question, so that's the reason why the female respondents percentage is comparatively very low compared to the male participants. Further, I would like to mention that the working population which we have selected, mostly in our days, working population is mostly the female population. That's the reason why the figure is more towards the male community. This is the age group of the 16 to 56 we had selected. 37 to 46 years we had 46%. From 47 to 56 we had 18%. From 17 to 26 we had 10%. And 27 to 36 we had 24%. This is the qualification of the participants we had. If you see, high school pass out was 35%, intermediate, that is class 10, we had 28%, postgraduate 2%, graduate 3%, and basic schooling around 9%. Obviously, once a person has got a hearing problem, that actually, so far as communication challenges are concerned, that impacts his or her study as well, which is also reflective in this case. That's the reason why we have got illiterate percent of 23. Moreover, if we compare with the census figures, it is quite near to what we had identified. Next, the occupation. Here, if you see, the government service holders is around 40%, service of the private 21%, business 11%, and professional 28%. Mostly, since the state government as well as the central government does provide quite a few facilities so far as hearing impaired patients are concerned for buying hearing aids. So that's the reason why people who are working in the government service are more inclined to buy hearing aid. which is reflected in this figure. Another thing which I forgot to mention here, the study has been conducted in 4 districts of West Bengal, which is your Nadia, South 24 Parganas, South 24 Parganas, and Kolkata. And in this region, although it's mostly urban, but rural population is also there. So the figures which we have received is a reflective of both urban as well as rural populations. This is the monthly income. Obviously, it shows a higher monthly income compared to what the normal monthly income of our country is there. It's mostly because of the people, 40% of the population coming from government service. That's the reason why this figures shows comparatively a higher amount. Then we have the marital status. We have 13% married, single 53%, widow and widower 9%. Here also it's a reflecting of the fact of the acceptance of hearing problem in the society. Since till date hearing problem is not accepted with much acceptance compared to a visual impairment. That's the reason why 53% of the population is single. Now we move to data analysis and interpretation. So far, data analysis and interpretation is concerned, we had the of these 7 constructs, we did the mean and standard deviations, where the scores had been around 3 in all the constructs we had. The so far as orthodox beliefs and customs, the mean was 3.454. Where the social stigma impacts the purchase intentions, mean was 3.429 and standard deviation was 0.935, and hearing aids are used by only deaf people. We had a mean of 3.411 and standard deviation of 1.025 in the respective contrast of orthodox beliefs and customs regarding purchase intention towards hearing aids. Next, so far as the price sensitivity is concerned, here we had a mean of 3.3523. Among the available multiple payment options, the impact of the final decisions mean was 3.305 and standard deviation of 1.011, and discounts and offer impacts the selection process, mean was 3.318 and standard deviation of 0.982, and respective constructs of price sensitivity regarding purchase intention towards hearing aid. Then we had the perceived benefits. In perceived benefits, we had a mean of 3.407, where the hearing aids are affordable. This was one of the question where mean was around 3.465 and standard deviation of 1.028. Jointly, the battery usage and cost impacts decision and hearing aid can be fitted, mean was 3.385 and standard deviation was 1.079. The hearing aids effectiveness and performance mean was 3.323 and standard deviation of 1.063 in the respective constructs of perceived benefit regarding purchase intention towards hearing aid. Next, we had the disease and health issues, where the mean was 3.246. Cold nausea impacts purchase decisions, mean was 3.246 and standard deviation 1.035. Disease inherited genetically, mean was 3.239 and standard deviation 1.006. And chronic disorders impacts purchase decisions, mean was 3.195 and standard deviation 0.956 in the respective constructs of disease and health issues regarding purchase intention towards hearing aid. Next, we had the physical comfort, whose mean was 3.522. Improved communications mean was 3.485 and standard deviation 0.970. Listening in different environments mean was 3.467 and standard deviation 0.959. And lastly, hearing and solves loneliness mean was 3.406 and standard deviation we had 0.944 in respective construct of perceived comfort issues regarding purchase intention towards hearing aids. Lastly, so far as the purchase intention towards hearing aid is concerned, the mean was 3.51. Geographical locations impacting decision making, mean was 3.447 and standard deviation 0.947, and society influencing the decisions, mean was 3.411 and standard deviation 0.818 in the respective constructs of purchase intention of hearing aid.
Please continue.
Just a minute. The slides has got stuck.
Okay. You can take your time. Don't get tensed. Sometimes technical glitches do happen. Don't worry.
Sometimes closing the PowerPoint and restarting it.
Yes. Slide number
56. So far as the hypothesis is concerned, the first hypothesis we had considered, physical comfort does not influence the purchase intention towards hearing aids. And during the study, we had found that the p-value was 0.00, and this thereby we concluded that since it is below 0.05, we had concluded that the null hypothesis is rejected, and we had to accept the null hypothesis. We had to accept the alternate hypothesis, and we confirmed that physical comfort actually influences the purchase intention towards hearing aid. The second hypothesis we had, psychosocial factor does not influence the purchase intention towards hearing aids. In this case also the p-value was 0.00, which was below 0.05. So we concluded that the null hypothesis is rejected and alternate hypothesis is accepted, and thereby psychosocial factor influences the purchase intention towards hearing aid. Next, we had the price sensitivity, where we had considered that price sensitivity does not influence the purchase intention towards hearing aid. The p-value was 0.00, which was below 0.05. So we concluded that null hypothesis is rejected. Alternate hypothesis we had to accept, and price sensitivity plays an important role so far as the purchase intention towards hearing aid is concerned. Next, so far as perceived benefit is concerned, we had considered that perceived benefit does not influence the purchase intention towards hearing aid. Here also the p-value was 0.00, which was below 0.05. So we consider null hypothesis to be rejected and alternate hypothesis to be accepted. Thereby, perceived benefit does influences the purchase intention towards hearing aid. The fifth hypothesis we had, orthodox beliefs and customs does not influence the purchase intention towards hearing aids. The p-value was 0.00, less than the significance level of 0.05. So thereby the null hypothesis was rejected and alternate hypothesis was accepted. Thereby orthodox beliefs and customs also influences the purchase intention towards hearing aid. The sixth hypothesis we had, disease and health issues does not influence the purchase intention towards hearing aids. In this case also the value was less than 0.05. So we had rejected the null hypothesis and concluded that diseases and health issues does influence the purchase intention towards hearing aids. The seventh hypothesis we had considered was service expectation does not influence the purchase intention towards hearing aids. The p-value was 0.011, which was less than 0.05. So we had rejected the null hypothesis and considered that service expectation does influence the purchase intention towards hearing aids. Then we had the T-tail test so far as the gender opinion is concerned, where we had seen that the male and the female do not provide any difference of opinion. So we concluded here that null hypothesis is accepted and gender does not affect the purchase decision of hearing aid. The ninth hypothesis we had so far as the age is concerned, where we had seen that the age group statistically actually influences the purchase towards purchase intention of hearing aid. So we had to conclude that the null hypothesis is rejected and age actually plays an important role so far as acceptance of hearing aid is concerned. Then, so far as educational qualification is concerned, we had seen that here also null hypothesis was rejected and alternate hypothesis had to be accepted. Thereby, we concluded that education qualification of the respondents does impact so far as purchase intention of hearing aid is concerned. The 11th hypothesis, which we had considered that occupation, so far as affecting the purchase intention of hearing aid, we concluded that the null hypothesis was rejected since the p-value was 0.016 less than the required figure of 0.05. So we concluded that null hypothesis is rejected and concluding that occupation plays an important role so far as purchase intention of hearing aid is concerned. Next, we have considered income. In case of income also, we concluded that null hypothesis is rejected and we confirmed that income plays a very important role so far as purchase of hearing aids is concerned. Based on this hypothesis, we come down to the conclusions, the limitations, and the future scope of the study. In our hypothesis, we had seen that the 7 constructs with which we had started the journey, all of them affects so far as the purchase decision is concerned. So that's the reason why we say that all these 7 factors, starting from personal benefit, physical comfort, psychosocial factors, service expectation, orthodox beliefs and customs, disease and health issues, affects the purchase intention. Now we look into the uniqueness of this thesis and comparison with the existing literature. Here we would like to say here that we have done quantitative findings as well as we have done a qualitative finding also so far as the focus group discussion is concerned, where the data analysis along with the quality we have tried to come across to make a data integration in a proper manner. We have done a regional focus where we have looked into the socio-cultural influences which impacts the purchase intention, adding diversity to the existing literature. We have also considered the new understanding in the underexplored field of hearing healthcare so far as the factors such as the service expectation. In very few studies earlier, we had seen service expectation was considered, but during this thesis, it was identified that service expectation is one of the key factors so far as selection of hearing aids is concerned. So far as the quantitative findings goes, the factor analysis, we had identified 8 significant drivers, the 7 constructs which I have already said, along with the purchase intention, the price sensitivity, which is generally considered as the most critical factor, reflecting the regional economic challenges and affordability issues. But in our study, we had found that rather than not only price sensitivity, but other factors such as physical comfort and psychosocial factors does influence more so far as purchase intention is considered. And the findings underscores the importance addressing both the economic and social consideration in hearing aid adaptation strategies. Then we come across the qualitative findings. In the qualitative findings, we had in the focus group discussions, we had numerous engagements with 34 participants where a great deal of information we had derived. The participants mentioned that they faced stigma so far as hearing loss is considered, which has been already addressed in previous studies as well. But based on the socio-economic pattern, we identified that it was more in the case of the female population than the male population. The unique cultural beliefs and customs regarding hearing loss were identified so far as the regional nuances are considered. Social support, especially family members, overcoming this barriers to hearing aid adaptation the the support of the family members, how they accept hearing problem was one of the key factors so far as purchasing of hearing aid is concerned and thereafter using of hearing aid. Finding emphasize the need for cultural sensitivity intervention so far as to reduction of stigma and promote the acceptance. We had certain unexpected or non-significant findings in this research also, which relates to the price sensitivity, which was mostly mentioned in other researches that as a key factor, but we identified that price sensitivity was not as the dominant factor so far as hearing aid purchase is considered, contrary to the traditional assumptions. Psychosocial influences, service expectations were identified as a pivotal role. So far as service expectation was mentioned in very few literatures as one of the factors, but in our study we did found that service expectation takes a major role so far as identification of hearing aid purchase is concerned. There was no significant difference in the gender so far as purchase intention of hearing aid is concerned. Which indicates a uniform perception regarding the value and need for hearing aids across the gender, but this also differs with the previous literatures which we had undergone. Factors related to service expectations such as after-sales support and warranties emerged as more influential than it was initially expected. Next, we have the contribution to knowledge, advancing the understanding of hearing aids adoption in India. We had the study actually provides the integration of both qualitative as well as quantitative findings. We had considered 8 factors, the 7 factors which I had mentioned, the psychological, social, cultural, the practical considerations specific to West Bengal. We had a robust quantitative model which is developed to quantify the relative importance of each factor and their combined impact so far as purchase intention is concerned. The findings provide actionable insights for the stakeholders, aiding to the creation of effective marketing and service strategies tailored for the Indian economy. The research contributes to broader understanding of hearing aid adaptation, understanding and addressing those gaps in existing literature and practices. The practical implications so far as empowering the stakeholders for local impacts. This is so far as what this thesis is helpful. The manufacturers and retailers actually can leverage the findings to create regional and specific products and services that can improve physical comfort and can address the societal stigma and cultural beliefs. Healthcare professionals can make a tailor-made counseling programs which can provide cultural sensitive supports, which can help patients to navigate the psychological barriers and practical considerations. The stakeholders can improve the access to necessary resources and support for individuals with hearing loss. And overall, we can say the finding empowers various stakeholders to enact positive change within the hearing aid industry and healthcare community in West Bengal and beyond. So far as recommendation for stakeholders is concerned, the recommendations are: first one, increasing the funding and coverage. Although there hasn't been any form of subsidies and other forms are there, but we advocate for higher funding level and enhanced insurance coverage specifically for hearing healthcare services. Public-private partnerships so that more private organizations are involved with government projects to make an effective, culturally tailored awareness campaign about hearing health. Affordable hearing aids, which focuses on specific needs and requirements. The research and development program should be devised in such a way so that hearing aids are cost effective and are of the state of the art technology. Flexible financing options so that all people having hearing problem can afford hearing aid, to implement a innovative financing solutions such as lease own programs to make hearing devices more financially accessible. Healthcare training, provide targeted training for healthcare professionals in cultural sensitive communications and effective use of assistive technologies. Teleaudiology expansion. This is especially in case areas where audiologists or healthcare clinics or doctors are not available, because in remote areas also people do suffer from hearing problem. If we have a robust teleaudiology program, we can take care of people in farthest areas. Referral networks to create a robust referral system to connect patients with available financial assistance and relevant support resources. Conclusions from the study. The conclusions which we had is hearing aid purchase intention is driven by numerous interacting factors. We had the non-financial factors such as the psychosocial benefits, perceived value, service expectations, which significantly influences decisions, outweighing the price in some cases. So far as West Bengal context is concerned, we had the socio-cultural landscape, which actually, so far as the social cultural landscape was there. The data and integration, we had a qualitative as well as quantitative data study, which provided a more comprehensive understanding. Age significantly influenced purchase intention, but the gender does not. Higher education and income levels correlate with increased purchase intention. Government employees show higher purchase intention than occupational groups. Obviously, this is because of the different government supports which comes up for hearing impaired people. Urban areas exhibit higher hearing aid adaptation rates than rural areas. Results strongly support targeted interventions addressing affordability, stigma, access to care, and highlighting non-financial benefits. The limitations of the current study. The study was conducted for a small sample size of 389, which is specifically restricted to 4 districts of West Bengal. Further, we had data where the data was self-reported. Many cases when respondents had recall bias, they didn't remember many things. They had a social desirability as to speak what others would feel good. So the data which they had provided, we cannot say that that was fully foolproof. So the error factor was there. Insufficient factor analysis. While 8 factors influencing purchase intentions were identified, their interactions and nuances were not fully explored, although we tried to understand their interrelationship, but to the fullest extent that was not possible in this study. Probably in a future study we can do that. Data capturing was done on a cross-sectional basis. Obviously, this has got a limitation. It would have been better if we had gone for a longitudinal study. Absence of brand preference. No data were collected for specific preference for hearing aid models or brands, which is important for manufacturers, because from the manufacturer's point of view, they would be more interested as to which brand is preferable so that they can work more on the R&D. Future research direction. This suggested research includes larger, diverse samples, deeper exploration of factor interaction, longitudinal designs, and brand preferences, assessments to enhance understanding of hearing aid purchase intention. Suggestions and recommendations. The first one is targeted marketing. Need to create a case-specific marketing strategy, highlighting features appealing to younger and older users. Next, enhance product design so that it has got a cosmetic look. Prioritize the development of lightweight and discreet hearing aids to improve comfort and the aesthetics looks. Stigma and reduction campaign to launch educational initiatives to normalize discussions about hearing loss and promote success stories. Insurance advocacy, lobby for better insurance coverage for hearing aids to reduce financial barriers for users. Partnerships for accessibility, collaborate with non-profit and manufacturers to subsidize hearing aids cost and improve access. And community engagements, implement workshops and campaigns to raise awareness about hearing health benefits. The future research which can be undertaken from this research is utilization of artificial intelligence and machine learning, adopt multi-method approach where diverse data sources and methods to assess same constructs and improve constructs validity, measure moderators and mediators, to develop a specific measures to clarify their role in relationship between constructs, employ data triangulation while combining the qualitative interviews, observations, studies, quantitative surveys for a comprehensive view of constructs, integration of artificial intelligence with mixed methods, whereby merging artificial analytics with multi-method research to enhance data richness and validity, refine conceptual framework, continuously improve the constructs definition by integrating insights from varied measurement methods. With this, I conclude my presentation. Now, the examiners can ask their questions.
Yes, Dr. Rajendra,
Yeah, yeah.
I request you to.
Very hearty congratulations to Mr. Anjan Niyogi for a very detailed and exhaustive presentation. I congratulate the research scholar and his research guide and the ICFI University for having chosen a very novel topic, that is analysis of the factors influencing the purchase intention of hearing aid users in West Bengal, India. This is novel because they have touched upon an area of hearing aids which is new, not much researched upon. Also, it has quite a lot of significance to the persons who work. It has significance, a social significance. It has a social stigma attached to it, as well as it has an economic bearing because it affects the work life of people. Plus, it has a business angle to it because these hearing aids have a lot of commercial value. So if you look at all this, it has been a very nicely chosen topic, a unique topic, for which I congratulate the research scholar and his guide. Yeah. Having said that, the research scholar has nicely brought out the issues concerning the people who are suffering from hearing problems. He has nicely brought out the social issues attached with it and has nicely profiled the users and has brought out the relevant concerning matters with regarding to this research topic. One particular aspect that I'm very much happy about is the way in which the research scholar has addressed the issues concerned by me in the questions that I had asked upon scrutinizing his thesis threadbare. So it shows a lot of sincerity in his action taken report. So I think a lot of effort has gone in from the research guide and the research scholar in addressing these issues which were raised, and the action taken report has been very nicely brought about, right? Another approach that has struck me is combining both qualitative and quantitative analysis. The focus group discussion has brought out the issues from the horse's mouth, the people who are concerned with the hearing aid issues, and framing objectives which are elaborate, as well as the hypotheses which are plentiful and covering all issues. And the research scholar has also shown a lot of competence in the data analysis techniques, both qualitative and quantitative. Right? So this shows the interest of the researcher towards the cause of research, because not many researchers would go a long way in trying to use multiple research methodologies, to do their research analysis, right? So all in all, it has been a very good research work. Though there was some lacunae that was pointed out, the research scholar and his guide have been up to the mark to address all of them, and that shows their sincerity towards the cause of research, right? And most of the questions that I had have been addressed in the presentation itself. So I have just a couple of questions now left, namely, uh, how would you look at your contribution of the research work towards the body of knowledge, right? You have done a very good work. Now, how would you as a research scholar look towards the contribution of your research work towards the body of knowledge? What is its unique contribution?
So far as the earlier researches that has been conducted, and what I found out that the socio-cultural factors was not properly taken care of. During the study, we have seen the focus group discussion. People have delivered their personal problems, challenges, which needs to be taken care of more seriously in more research. So I feel in the body of knowledge, this socio-cultural factor is one of the key important thing that needs to be considered, and especially the two models which I have considered in my study, the health belief model as well as theory of planned behavior. There also the impulse is there so far as purchasing a product or anything is concerned, where the socio-cultural factor hasn't been there. Though I'm not saying to change the theory, it would be a very it won't be right from my side to say such thing, but I can say that socio-cultural factor, if considered along with this, would actually define these studies.
Okay, good. Now, another question is that you have lent upon the theory of planned behavior in your research work. Yeah. And that theory has certain constructs, variables, and interconnectivity. Now, post this research, do you find that the theory has got entirely validated, or you feel there is a new way or new dimension of looking at the theory itself, or some new additions your research work has brought on, which adds more value to that theory?
In continuation with my previous answer, I would say the socio-cultural factor needs to be added upon. Further, as hearing aids is a product which has got a shelf life of around 4 years to 6 years, the service expectation factor also needs to be considered when buying a theory of planned behavior. Maybe I would rather say that a product which is of durable nature, service expectation should be added upon one of the criteria.
So do you plan to send your research work to the policymakers in West Bengal or to the National Hearing Aid Board, such that they can take up this into framing some of the policies? So have you sent, or are you planning to send your research work to any persons who would make policies?
Definitely, sir, I would like to do that. Definitely, I would like to do this.
Okay. My other questions have already been answered by the research scholar in the presentation. So if the other panel members have any questions, you can please ask.
Dr. Deepak Verma from NIT Jaipur is there. Dr. Deepak Verma.
Namaskar, sir.
He is another examiner,
Yeah.
but come to the university for the White House.
Yes.
So now you are able.
First, congratulations, Mr. Niyogi, for completing and compiling this massive document. So, few very generic questions. The work has already been done, so there is nothing that we can revise. We can always improve in further studies. So, I would like to know why specifically focus on West Bengal.
If you see, West Bengal has got a little bit of cultural difference compared to the other parts of the country. It's quite obvious, I see West Bengal, so I selected West Bengal, but that should be the answer. Here, there is a specific the stigma. When I say the seven constructs which are considered, one of this is a stigma. There are quite a few orthodox beliefs, not only in the rural areas, but in the urban area also, that people nowadays also feel that using a hearing aid will actually make them ears more bad than giving them a normal life. So this was one of the factors I have considered. Although I have only considered 4 districts, so there are around 20 districts in the
What I wanted to know that you have mentioned multiple theories over here, right? 4 P's, 7 P's,
7 P's,
and then
purchase plan.
yes, and then you have also mentioned certain technology option theories, theory of planned behavior and things like that. Yeah. So, how you have derived your constructs from these models?
If you see the theory of health belief model, in health belief model we have got the suspectability, then the different types of barriers we are talking of. When I'm talking of the theory of learned behavior, we are talking of the attitude so far as acceptance is concerned. If you see the major 7 constructs which I have mentioned, those constructs as somewhere down the line have got an integration with the model which I have mentioned.
Okay. So, there was simply an observation. You have mentioned that those 7 P's are basically from witness model, right?
No, it's not 7 P's. I'm talking of these 7 constructs.
7 constructs. Okay.
7 P's also, sir, what I have done. If you see I've written the 7 P's in one of the pictures, and in the next picture, that in the right hand side, I have mentioned how hearing actually is integrated with these services.
I have my doubts on that because the people here means the people who are actually delivering the services. The 7 P's model was developed for service organizations. This was extended model of 4 P's given by McCarthy, expanded by Bittner, No and Bittner. This, for example, just the people part that you have written, the actual buyers of hearing aids, right? Consumers are not people here in the model. People are people who delivers this service.
Okay, the service providers.
Service providers, yes. So there are certain issues with this conceptualization, but fine. What I specifically wanted to ask, how you have derived your constructs and their items, how you have operationalized your constructs.
Constructs, basically what I have done, I've done the literature review on that, and based on the previous literatures, what constructs they have considered, I've tried to bring them, narrow down my concept.
Why these 7?
There were others also, but this 7 were mostly, I would say, used. Although service expectation, if you say, I had, it was given, although the literatures were not much there, but since I am in this industry for nearly 15 to 20 years, so based on what I had seen, I had tried to include this.
So the selection of the concepts was clouded by your own experiences.
No, it was a little bit of my experience, but mostly literature, but along with the practical knowledge I had.
This brings me to another, I shouldn't call it an issue, but you have identified so many gaps, but you have picked only a few of those.
Yeah.
Why?
Yeah. This, I would say, obviously, in a research, you come with lots of things, but you have to narrow it down.
I understand that, but my point is, when you have identified a research gap, why have you left it open?
There is always scope of other research.
Then you should have not mentioned it in your gap identification, literature review gaps. You should have mentioned it in your limitations. That these could have been addressed. Yes. Yes. This was the point I also made in my report.
There was a suggestion that given you have incorporated.
Yeah,
So
I've mentioned that in the.
You have removed some of these.
no, almost none of my comments you have addressed in your action ticket. So the idea is that when you're somebody might ask why this charity? Why one of the gap was more important than the other gap?
Okay, understand. So, what is the
Yes,
weightage
you
and
have addressed certain gaps, your model justifies those gaps, I understand that particular thing. The idea is that why list so many gaps and then pick some? This becomes sort of charity. Now, either you need to explain why these gaps were more important than the other gaps, or you need to somehow justify why only these were picked up. Why other were left?
As I said, first, so far as the age group is concerned, I mentioned also that 16 to 56 years, this is the most vulnerable group. Very less research has been conducted in this.
I understand your point, but I just wanted to give you feedback that you can, in future, you can work on that. If you are addressing certain, if you are identifying certain research gaps, you should focus on all of them. Otherwise, it becomes a question why you have addressed them when you have left them. Right? So, the next part is you have done focus group interviews as well as you have done a quantitative study, qualitative as well as quantitative study. How you have merged these two? Were there any synergies? How these two are linked?
Yeah. To be honest, although qualitative data we had done in the focus group discussions, but we haven't done any analysis for the focus group discussions. We have tried to portray what were the challenges they were facing. So the analysis was mostly with the data that was collected for 389 people. But the intention was not only just to come out with a mathematical figure and prove that this is correct or this is wrong, but also to have the understanding of the user who is using the hearing aid, because there are many things, questions when we are drafting, we are actually putting a closed-ended form, and whatever we are intending.
But did you try to take the inputs from these focus discussion groups and convert it into questions?
Questions in the sense, during the questionnaire, after the pilot study, we first we did the focus group discussion. And based on it, after the pilot study we had done, of the 70 respondents we had, and we had 47 questions. Then we actually
did focus group discussions after the pilot study.
After the pilot study.
Then your sequencing is a bit off.
That means in two parts actually I have done. I haven't done a single day. Actually,
I understood that thing, but usually what you do, either you do your qualitative part first and then quantitative, or you do quantitative first and then use qualitative. You do not mix two. Right? It's a standard practice. You do not mix two. There are models which are called mixed theory models, but you have not used those models. You have not used that methodology. You have used a mixed methodology and used quantitative as well as qualitative, but there need to be differentiation in phases in which you have done your qualitative and quantitative. You also have changed your questionnaire substantially post your pilot study. What made you change those? Made you make those changes?
As I said, one is a reliability test. And then the focus group discussions. Actually, when I understood that people are talking of the service expectations issues more, because so I felt that it should be also taken, more questions needs to be put on the.
But then you have used the questions.
But few questions are left out. From 47 to 43, around 10 to 12 questions are left out. And
They were added later.
47 question was
But they,
in the pilot
yes,
study.
yes.
From 47, we had reduced to 35, plus we had 8, so 43. And the Likert scale from 7, it came down to 5.
Why did you change from 7 to a 5-point scale?
Because actually it was, during the calculation, it was, because are you satisfied? How much the satisfaction level user was more dependent on us rather than giving their opinion.
And I still find that there is an issue with your scale. The issue is that most of your mean scalar scores, they are in the range of 3.2 to 3.5.
Yes.
Mostly less than 3.5
Yeah.
on a 5-point scale, which will be towards neutral. That means they do not influence. Right? For example, price sensitivity, it is 3.35. 3 is neutral, 4 is
4 is towards
4 is agree, right? So what were your itemization like? Strongly disagree, neutral, strongly agree, strongly agree. Most of them are towards neutral.
Neutral or agree, not strongly.
Not even agree. They are less than 3.5, so they are towards neutral. Right? There might be interaction between relationship between constructs, but they themselves are towards neutral.
Yeah. But since it's above neutral, so we have considered this positive.
The biggest irony I found is that disease and health issues has a 3.24 mean scalar score. You are having a hearing problem and you are not concerned about your disease. That is coming out to be neutral.
This was what the opinion we had received. I have changed.
I understand that. But you say you have done factor analysis of this. There is no, what you can say, output of factor analysis other than commonality or a factor model of 6. This commonality KMO, yes, fine. This commonality and this total variance explained. Where are the factor loadings? There are no factor loadings on the. And then you have also talked about SCF, right?
Yes, sir.
You have in that also not talked about CF. You have talked about discriminant validity. I seriously wanted to see this discriminant validity. You have only talked about what is called formal Lacquer criteria, which is an outdated method. You have done work, but the thing is that what I want to emphasize is that you have done work. The issue is that you also need to display that work. Management में जो दिखता है marketing वालों के लिए खासकर you can sell only what you see, right? जो दिखता है ना. So बहुत कुछ दिखाने का था जो दिखा सकते थे नहीं दिखाया. Okay, you had a point that females didn't respond, and they were almost 24%. Is this hearing problem equally distributed between male and female? Or are females or males more susceptible to hearing problems?
In which sense?
No, in general.
No. So, I think for both.
it's equally equally. Then there is a bias in the study.
Bias in the sense, as I said, that people, females due to their,
And do you know the reason why? Can you identify the reason why?
yes, because they do not want to disclose their hearing problem.
Probably they also didn't want to disclose their identities.
Identity, we hadn't considered the identities,
But if you have mentioned the identities of who were the part of your focus group discussions in this thesis?
no. Only the qualitative data. The quantitative data, if you see the Excel sheets which are given there, sheet those ones.
For example, for focus group discussion, I can see somewhere written the principal of RGR Medical College.
And this is the overall viewpoint of the doctors, they are saying.
So they are doing what?
This is the opinion of the advisors, the doctors. And not talking of the respondents.
So why mention anybody by their name?
This is the, one of the questions that was provided by the examiners that you haven't included the opinion of the advisors.
No. Right, you can provide opinions of the experts, but you never identify them in the research. You never identify the respondent in research. Respondent 1 to 3, you might have done.
You haven't mentioned the name of the.
But who is the principal of RGR College? Anybody can know. Right? Who is the managing director of WS Audiology? You have identified them. You have identified individual by name in their responses. Excel sheet, which is basically not a good practice. People will stop responding to you. It's just name. The idea is that it's just name, but you have identified them with name. Then they would be very apprehensive of giving you information. Probably if you would not have used those questions in your questionnaire, name and you included in this particular thing, not in your presentation, religion. I pointed that out. How is religion related to this?
Religion, it was just one week. I haven't done any study for that.
That is the question. Why ask for something that you are not going to use? People get very, very apprehensive when they see these kind of questions. They will stop responding. Ask only those questions which you are going to use in your study. And never ask questions which are personally identifiable. You do not need to analyze on the basis of names. Why ask their names? Code your questionnaires, give them numbers, serial numbers. You need only a unique ID of that questionnaire, right?
Yeah.
Why ask their name? Give it a number.
Yes. Just for the sake of name.
So it's not very prevalent in our country, but slowly it's picking up. There are some people actively go. Right? If you will send your questionnaire, your study to that particular book, they will never approve anything which is personally identifiable information. Right? There were certain smaller issues with your presentation. For example, beta values you have used capital B. Right? For T statistics you have used capital B. They are not used there. We would expect somebody who has completed PhD to know the difference between capital B and lowercase b. Right? These are small issues. Right? The other issue that I had with your thesis, which was supplied to me and still there, many of them have been taken care of. Tables, for example, they were in very poor shape in the individual part, but still, few of images are still not readable. Your SCM model is not readable. I cannot make, even with magnifying glass, which construct is which. It's not simply state of the these things are not simply state of printing, they has to be read now. मैं अपने पीजी स्कॉलर को बोलता हूँ, ये जो है ना, ये आपकी बीवी से दूर है। आप बीवी से तलाक ले सकते हो, आप इससे तलाक नहीं ले सकते। ये पूरी उम्र के लिए इट्स रेडी टू यू, तुम चाहो कि नहीं चाहो, ठीक है? तो आइडिया इज दैट, तो इसको जितना सजा संवार के रख सकते थे ना, उतना बेटर हो। सी यू कैन नॉट रीड दिस फीलिंग, एंड दिस इज योर कंसेप्चुअल फ्रेमवर्क, दिस इज योर फ्रेमवर्क जिसके ऊपर तुमने सारे के सारे रिलेशनशिप्स आइडेंटिफाई किए, सपोर्ट किए कि नहीं, है ना? So small things, जो as a PhD scholar, right? PhD is not about doing research. मेरे supervisor बोलते हैं, PhD is not about doing research. It's learning how to do research. I hope you have learned how to do research. Congratulations.
Yes, sir. Dr. Dr. Deepak Verma, he can declare.
Sure, ma'am.
Okay, sir. Sir, 2 minutes you be online, I'll call the registrar.
Okay, ma'am.
JB Patna.
Good afternoon, sir.
Unmute, sir.
Unmute from his end.
So your mic is on mute. Sir, your mic is on mute.
Yeah. Hearty good afternoon, sir. It's been a pleasure to be part of this process.
Thank you, sir.
How is the presentation, sir?
Yeah, he did the presentation well. In fact, most of the questions that I had asked, he has addressed it. Though there were a couple which he has not addressed, which I felt it is not apt to put forth in this presentation part. That I leave to the researcher to carry it forward. But overall, it has been a good presentation, a good area to touch upon, and the lot of sincerity has been shown in the research scholars' work. Though no research is complete in itself, but I think it's a good beginning for Mr. Anjan Niyogi to start his actual research journey from now. So this doctoral presentation is actually the first phase of his greater research journey that is to begin from now.
So, sir, your opinions should we declare the scholar Mr. Anjan Niyogi to become the Doctor of Philosophy in Management?
Yes, yes. I think you're as meeting all your protocols of the ICFA University. I think Mr. Anjan Niyogi is fit to be declared to be a doctorate in management based on his thesis and his presentation. So you can follow your protocols, norms, and then can consider him favorably for award of the PhD degree.
We also request, sir, Dr. Deepak to declare.
We have already declared, sir.
Thank you, sir. So we are part of the ceremony after success. After successful completion of the process, I request to declare Mr. Anjan Niyogi to be the Doctor of Philosophy in Management. So kindly declare so that we will award him.
So we declare Mr. Anjan Niyogi to be here for the titled as Doctor in Engineering.
Congratulations.
1 second attention towards this phone. Thank you.
Hearty congratulations to the research guide and to Dr. Anjan Niyogi now. Hearty congratulations.
That's a small
Yes, sir. Thank you very much for your
respect from
comments.
ICFA University. And we again and again, he helped us in this aspect.
Just a second. Thank you.
Thank you, sir. Thank you, sir.
It's been a pleasure being associated. Thank you so much.
Thank you, sir.
Thank you, Dr. Rajendra. This is Dr. Manisha here.
Yeah. We have spoken. Yeah, nice meeting you, ma'am. It's also a pleasure meeting. Thank you, ma'am. Thank you so much. It's also a pleasure meeting Dr. Deepak Kumar and trying to, I liked the way he has asked the questions. It's a nice way to connect to stalwarts in the field of management education. Happy to meet you, sir.
Thank you, sir. Pleasure is mine.
Thank you
Yeah,
so much,
yeah.
sir, for evaluating my scholar's thesis and for
Yeah.
giving all the valuable suggestions. Your suggestions we have tried to take to satisfaction, but still, so if something is lacking, why it will be a learning for both of us, my scholars and my and for me, we will take it forward. Sir, thank you so much for the time and for the patience you maintained to go through the thesis and again the evaluations. Thank you so much, sir.
And pleasure is mine. Best wishes to the research scholar.
Thank you.
Thank you.